Our next speaker is Dr. Suhaas Muralidharan, which I never get right, I apologize. Who's a PhD student working with me. He's from Purdue University.
Thank you, Sarah, for the introduction. Good evening, everyone, and thank you for joining me today. My name is Suhaas Muralidharan, and I'm a PhD student at Purdue. I work with Dr. Sarah Queenie, and the title of my talk today is Stereoselective Labetalol Pharmacokinetics in Pregnancy. So to give you some background, HTPs are blood pressure disorders in pregnancy that can lead to maternal as well as fetal complications. So the maternal complications predominantly include preeclampsia and eclampsia, whereas they can also increase the risk of developing cardiovascular disorders. The fetal complications that can affect, that are life-threatening are predominantly placental abruption, preterm birth, and stillbirth. Now, HTPs affect about 18 million pregnancies every year, and they are a leading cause of pregnancy-related morbidity and mortality. So what are the treatment options? Well, labetalol is the first-line drug that's used to treat HTPs, and it's also the most frequently used drug to treat HTPs in the US. But despite its widespread use in pregnancy, clinical data shows inter-individual variability in its exposure and response, and this can lead to poor blood pressure control in pregnancy. So to understand where this variability may be coming from, let's look into some of the knowledge gaps. So firstly, the metabolic pathways of labetalol remain poorly characterized, and the mass balance studies only account for about 80% of the dose. And while UGTs are thought to be the predominant pathway, metabolic pathway, CYP2C19 polymorphisms have also been shown to affect labetalol exposure in Chinese healthy males. Moreover, the specific contributions of these enzymes towards the pathway of labetalol remains unknown. Secondly, we also know that from talks of yesterday and today, we've heard that pregnancy is a dynamic physiological state, and it can alter the pharmacokinetics of drugs. But despite labetalol being predominantly used in this population, we do not know the impact of pregnancy on its metabolic pathways. Moreover, current dosing guidelines or PBPK models do not account for the impact of stereochemistry of labetalol in pregnancy. And labetalol is a molecule that has 2 chiral centers, so this allows it to exist as a mixture of 4 diastereomers, and only 2 of them are pharmacologically active, that is SR and RR labetalol. So these diastereomer pairs are structurally similar, but they can have different physicochemical properties and differences in the way they interact with enzymes and receptors. And so these stereoisomers can essentially have differential pharmacokinetics. So the key takeaway is that these stereoselective differences may directly translate to fluctuations in blood pressure control in pregnancy. So this brings me to my objectives, which firstly is an ongoing clinical study that I am leading, where we're trying to characterize the pharmacokinetics of labetalol stereoisomers in pregnancy. And this will be what I focus on for the rest of the talk. But we also have a in vitro study that is aimed at characterizing the CYP and UGT pathways involved in the stereospecific metabolism of labetalol. And the parameters that we obtain from these experiments will then be incorporated into a PBPK model to develop, to validate, which will be validated using the data from the clinical study of AIM-1. So for the clinical study is an observational PK study in pregnant women who are taking labetalol as per standard of care. And we exclude any patients who have diseases known to alter labetalol pharmacokinetics. So in terms of the study visit design, we have patients who come in for their pregnancy visits as well as at postpartum. And we have them come in around their time of taking their labetalol dose. We do a baseline blood draw before they take their dose. Once they've taken their dose, we continue to do blood draws at 15 minutes, 30 minutes, and so on until 6 hours. And we also do a delivery samples, which mainly includes maternal blood close to delivery and cord blood. So the study visit typically lasts for about 7 hours. And so in terms of recruitment, we have currently enrolled 13 participants. And as you can see, 7 of them have completed at least one study visit. And so we have a total of 62 plasma PK samples in the second trimester, 26 in the third trimester, and we have 25 postpartum samples. And these are the demographics of those patients. So this is a key step in my clinical study, and this is where we're at right now, where I'm trying to develop and validate a chiral LC-MS assay to be able to separate the 4 stereoisomer peaks. And the key is to identify the ideal conditions to be able to separate them adequately so that they can be quantified. And one of the key challenges we've had previously is that the resolution of these peaks or separation at baseline was not adequate. And the time at which these peaks were appearing on the chromatograms were changing with successive runs. So the retention times were shifting. So as of now, with the current assay conditions that we've optimized, we have been able to solve this retention time problem and stabilize the retention times. And as you can see, we've also obtained reasonably good separation with the peaks. So I wanted to circle back to my overall approach. So we have the ongoing clinical study, which helps us generate stereoisomer PK profiles for labetalol. And then the in vitro experiments, which help us identify the major metabolic pathways of the labetalol stereoisomers. And then the input, this will be used as inputs for the PBPK model, which along with the changes, integrating changes in physiological changes for pregnancy will help us simulate the labetalol stereoisomer exposure in pregnancy. And these simulations will then be validated with the clinical study, the clinical data from AIM-1. So to conclude, this work is focused on moving labetalol dosing out of this black box. And by defining the stereoisomer specific pathways, we can hopefully understand why some patients may face treatment failure, while others may be at a greater risk of toxicity. And my work is focused on building this mechanistic foundation for individualized dosing of labetalol in pregnancy, and hoping that one day we are closer to trying to improve blood pressure control in pregnancy. But with that, I'd like to acknowledge my mentors, my PhD committee members, the study team, and of course funding, without which this work would not have been possible. Thank you for your time and attention.